I'm going to introduce our speaker today. Dr. Chris Stewart is an addiction psychiatrist who lives and practices in Louisville, Kentucky. He received his medical degree in 1997 from the University of Louisville. This is where he also completed his general psychiatry residency and his fellowship in addiction psychiatry. Dr. Stewart holds the rank of associate professor with the University of Louisville Department of Psychiatry and Behavioral Sciences. Dr. Stewart is the director of the University of Louisville Physicians Outpatients Addiction Program, the Inpatient Substance Use Disorder Service at the University of Louisville Hospital, and the training director of the Addiction Psychiatry Residency Program at the University of Louisville School of Medicine. He is board certified in general psychiatry, addiction medicine, and consultation liaison psychiatry, and he is a certified group psychotherapist with the Internal Registry of Group Psychotherapy. So everyone, welcome Dr. Stewart.
Thanks for that. Thanks for the introduction, and thanks for having me. It's good to be here with, and it was cool to see the different counties. Some people from Boyd County were on there too, so my shout out to Boyd County. Hello, Michelle. So it's good to be here, and good to see everybody else too. Hopefully this will be useful and practical, and I'll talk about basically my experience over the years and my experience with the current situation that we're dealing with here in Louisville, and how it most likely applies to what you're dealing with too in your communities. Go ahead. So yeah, practice gaps and educational needs. Yeah, it still seems strange to me that we have some of these gaps, despite what we know about addiction and what needs to happen, but we do. It's really challenging to bridge the gap between what is needed and what our treatment systems provide. So we have to keep having meetings, and we have to keep trying and working really hard at addressing these problems. And if they were easy to solve, we would solve them. But there's just a substantial need to continue to put out the evidence that we know about addiction as a disease and how it needs to be treated. So you can go on, next slide. Hopefully, I understand that there's a pretty high level of competence in this meeting about medication for opioid use disorders. So I don't plan on adding necessarily to that, but again, in the context of obviously this presentation, we're talking about patients who are receiving medications for opioid use disorders and the kind of problems that we're encountering with this. Next. Yeah, and yeah, how's the epidemic with other substance use disorders, the epidemic with opioid use disorders, how is this really challenging us and really, in a way, sort of pushing us to, including myself, to really look at some limiting ideas and beliefs that I've had about addiction over the years, and what we can do about it to really improve the outcome among our patients. So I started in addiction. I did a fellowship in 2005. I completed my addiction psychiatry fellowship. I was already really involved in treating patients with addiction by that time. Mostly alcohol and crack cocaine were the predominant substances. We saw other prescription drugs were a problem back in the late 90s, early 2000s, obviously, but I was treating a lot of alcoholism and working with a lot of abstinence-based programs that were doing excellent work. And I really, that's what got me into addiction. So I still come from that and really appreciate that approach. So I was reluctant to begin using buprenorphine in my practice. I got my waiver when I was a fellow, and I really didn't start using buprenorphine to treat opiate use disorders until several years later, which makes me a lot like most of the other providers in this state, or a lot of other physicians and prescribers who get their waiver but don't use it. That's a common theme. And it was a lot of it was based on my resistance to the idea of prescribing medicine, prescribing an opioid for addiction to opioids. And it was also just based on just, not being comfortable with that, feeling like I didn't have the knowledge, which was true. And that changed when we recruited a faculty from outside of the state who came in from Idaho, who was an addiction psychiatrist and had been using buprenorphine in his practice. And he it demonstrated to me that it could be done really effectively. And so we started together, he and I started one of the first outpatient programs in Louisville in 2008. And we were, really taken with the treatment, particularly using buprenorphine naloxone for prescription opioid addiction, which was the predominant problem we had. We hadn't really had the problem with heroin surface yet, and it worked really well for prescription opioid addiction. And there was a ton of resistance in the community to that. We did face a lot of pushback and criticism, but it worked very well. Patients got better, and I'm still treating patients to this day from who started then, who are doing really well and have stayed on medication for that length of time. I was also at the same time the medical director of an inpatient service that was community-based, but was a medical detox, addiction-based hospital here in Louisville. It was called JDAC at the time, and I was the director there for 7 years. And that was very much in the traditional method of abstinence-based treatment, and so was not using or utilizing medications for opiate use disorder at the time. So I was doing, both at the same time, like many people did. And just tell you that, so that's kind of giving you information about where I'm coming from. And also, I moved to Chicago in 2014 and began I was medical director of a physicians impaired program, a partial hospitalization program for impaired professionals, where we had sort of a mixed model of using medications, but also still really being very conservative and very abstinence based. I came back to Louisville in 2018, and obviously the heroin epidemic had become a huge problem all across the country by then, and the funding became available like it did everywhere else, and we started an addiction consult service at University Hospital. So I was right when I got back to Louisville. We started a consult service. We expanded our outpatient services a great deal, and so. That was a good opportunity, but obviously not for good reasons. We're seeing a terrible, tragic epidemic that has been extremely destructive to our society, and it's only gotten worse with the pandemic. And having these services has been really very helpful, but seems to only feel like at times like we're scratching the surface. But I do feel like we're making a lot of progress, and as a system, we've made a lot of progress in Louisville with the attitudes and the ideas that are there now. So that's enough about that. I do have experience with a lot of different special populations, like most probably of you all. We work with pregnant women, and I've worked with impaired professionals, and across the spectrum of populations that you see in treatment settings. And in working in the hospital, I work with a lot of medically very sick patients who develop complications from IV drug use. And so that also, has really influenced probably my views about where we need to head with regard to treatment. Thanks. We can go on. So this is just a survey to sort of illustrate what we're talking about today, which is the idea that our patients are not really monogamous when it comes to their drug use, right? They don't just use one drug. They use lots of different things, and maybe they always did, and we didn't recognize it, but it seems like this has gotten a lot worse and makes it more complicated to treat our patients. They're using highly addictive substances together, and the idea that we can sort of identify people based on one addiction and they belong to that group and that's how we're going to treat them is probably in some ways old and a little bit out of date. We certainly don't want to say that heroin addiction is the same as alcohol addiction, or these are different addictions and different problems, but we do see them in combination, and we need to change our approach to fit that kind of patient that we're seeing. And so again, this is from the National Survey of Drug Use, a national survey that looks at the population as a whole, and again, sort of identifies what's going on with the population in the United States. And you can see alcohol is the top, tobacco, marijuana, those are the top drugs that we see, and then the other drugs are listed here. We're treating people who are using more than one substance, and they're using all these different substances. Recently, a few years ago, the Healing Place, which is a peer-based treatment program that I've been affiliated with for a very long time. And in Lexington there, a lot of people from Lexington here, I think the Hope Center has been affiliated with the Healing Place, and Recovery Kentucky was affiliated with the Healing Place model. And of course, that model has been hostile to medications for opioid use disorders. Maybe hostile is not a totally fair word, maybe just unwilling to, people want to do that. They don't want them coming to their program. They're abstinence based and have been for a long time. And they were really concerned about diversion with buprenorphine, which is definitely a problem. And that's not what I'm talking about with this slide. But what I wanted to bring in was they did a pretty extensive survey of their clients, and they identified what their top drug uses were, what their preferences were, and this got published. And it illustrates again, these are your top 3 preferred substances, and there's a lot of overlap. Alcohol, marijuana, and opiates were in their top 3. Heroin, obviously, they identified separately. It's in there too at a high rate. Stimulants at 37%. This has probably gone up since then. You can go on. Of those of you who use buprenorphine, what were your 3 preferred substances? Alcohol, marijuana, opiates again, heroin, stimulants. You can see the other breakdown. I think it's a useful look at what our patients who are coming in for treatment for opiate use disorders are also using. So next. This is from the Kentucky Opioid Replacement Treatment Program Outcome Study. So patients in outpatient treatment involving methadone or buprenorphine. This is from 2020 and shows and they come into treatment, 96% report, any illegal drug use, 73% opioid misuse of prescriptions, heroin 66%, and then 74% non-opioid drug use. So there's a huge overlap there. And they like to say, point out how the numbers go down. But the point here that we're making is, most patients, the majority of our patients are not using one substance. They're using multiple substances, and they're getting addicted to more than one substance. So it's not just that they're using 2 or one substance they get addicted to and a substance that they use, from time to time. That happens too, but they're probably addicted to more than one drug. All right, next. Again, this just added on to the depression, the anxiety, and comorbid psychiatric issues that these patients have. And it's extremely high as a value as identified by this study in our state. We can point to national data and say, this is the way it is. But when you can look at your own state and your own clients and your own patients and your own population, and it verifies that, I think that's important to notice. And again, it intake high rates of anxiety, depression, and again, suicidal ideation, suicide attempts are also something to be aware of in this population. All right. So polysubstance drug use among patients with opioid use disorders is the norm and not the exception. It's not an exception to what we're seeing. Most patients that we're going to treat for opioid use disorders with medications for opioid use disorders are likely to meet criteria for at least one other substance use disorder. So that changes the game for a lot of people and professionals. The natural question is, well, then should we be using an MOUD in these patients, right? Does it provide benefit? And yes, it does. And I'm going to talk about that. And I think that giving medications for patients who have opioid use disorders and other disorders facilitates treatment for their other disorders. As opposed to contributing to the problem, which is sometimes a criticism that isn't really founded, I don't think, with a lot of good information, but it's certainly a fear that I've had as a provider, that I don't want to contribute to someone's addiction problem. But I think really what we do is it really facilitates engagement. And that's what we'll talk about today, is that these patients are challenging to engage in a consistent way. To get them to return to treatment and engage and meet with people is a real accomplishment in and of itself. And we have to change the way we measure success in treatment, not to say we're going to water down treatment or accept a lot less. What we're doing is looking at when we're making changes, maybe we need to be more precise and more sophisticated about how we look at when we're changing things in patients with addictions, which I think is where everybody has been headed for a period of time. Next. So when we have patients who are using Sometimes patients come in, they're clean, they're not using any substances, they're on buprenorphine or methadone, they're doing well, but then something happens, right? And they either use another substance or they relapse with heroin. And so these are common scenarios that I have encountered in my practice. One is they're just not compliant. They're not taking their buprenorphine, or they're not taking the medicine that they're being prescribed. A lot of times the way I look at it is when you have a failure of treatment, that's exactly what it is. It is a failure of treatment. It's not something else. It's that treatment is inadequate to meet the problem. That's what you're being sort of faced with, is something is not, providing what is needed to help someone achieve a remission or achieve sobriety. And so inadequate treatment. Is your treatment inadequate? Are you monitoring enough? Is your dose inadequate? Are you seeing the person often enough? Do they need a higher level of care? And a lot of times you'll say, yeah, we need a higher level of care. We don't have that option. So what do we do then? We're doing everything we can. We're frequently in that. But again, a lot of times it's just maybe the treatment's inadequate. Patients are often in environments that are hostile to abstinence from drugs. And we need to understand that and get them to tell us about it. I have patients who have this problem with every substance that treat alcohol, any addiction. The environment's extremely important. We know that if people are using around them, it's not supportive when you're trying to abstain. And I still see abstinence as what I would call patients who are on medications and for opioid use disorder, and they're not using substances. To me, they're abstinent. So if I say that just for the purposes of this presentation, I mean patients are compliant with treatment, not using substances. They're abstaining from drug use. That may not always occur during treatment, and you can still have treatment even though you have slips or relapses. Okay. When people are using other substances, you don't want them to do that. And I want to just maybe that's too obvious or too explicit or seems redundant, but again, that does reduce the outcome. It makes your outcomes not as good. It does increase the risk of relapse to heroin if they're using another substance. So we do want to pay attention to that. On top of that, what we understand about addiction in the brain really supports this idea that using other substances that are potentially addictive is not really good for a recovering brain and can interfere with the recovery from addiction that can occur when patients take medications for opioid use disorder or medications for addiction as prescribed and do well. Their brains recover. But again, ongoing use of other substances can really interfere with that. The other part is, even though we do have brains that recover when we treat patients for addictions, they remain vulnerable to relapse. To me, I think there's pretty good evidence for heroin and opioid addiction that they're vulnerable to relapse indefinitely. I know that I have patients who've been able to do medication for opioid use disorder for substantial periods of time and then eventually taper off and seem to maintain abstinence after that. But I haven't seen that very often, and there's not a lot of data to support that that's something that happens commonly. What we see much more is once patients stop MOUD, they're much more likely to relapse. Okay. So I just wanted to put this in here. These gentlemen received the Grawemeyer Award at U of L in 2019. And it really was important to recognize this, what this was about. And for this talk, I think it's relevant. And they were the psychologists who did research on the brain. And we're talking about how something's happening different with addiction than just people having a good time. People would criticize people with addicts are just morally not fit. It's not a biological problem. It's not a disease. And also they're just doing something because they like doing it. And we need to punish them and make it so that they don't like doing it, so they'll stop. That was one of the ideas we had about treatment, right? And they were pointing out that this isn't the same part of the brain that likes things, that likes the way something tastes, for example, is not the same part of the brain that drives the urge to use drugs and alcohol or things that are addictive processes. They're powerful urges that are based more on wanting, and wanting is not the same as liking. And it's hard to get your head around. For me, it was, and comprehending that. But and having to learn about the research on the brain of addiction is really the only way that I've been able to sort of begin to understand this, other than working with people and being frustrated at what seems to be a powerful force that was not something that could be controlled and not something that could be reasoned with our patients. But this kind of explained that more from a biological perspective. 12-step recovery community has been talking about this for a really long time. So we don't want to say that this hasn't been talked about, but in this way, it's important to understand there's biological basis for what we understand, what we observe in addicted patients. And it's not simply, it's not just a matter of willpower or a matter of preference. It's not a simple choice. It's something more powerful and primal than that goes on when we have patients. And I imagine most of you all already realize that, and so I apologize if that's redundant, but I wanted to put this in. This is the incentive sensitization theory of addiction, which is, check it out if you want to. Next. So this is a model here, and I'll go through this quickly. Again, this is just sort of it's a nice slide about the brain and addiction. It's not the definitive slide or the most, up-to-date slide, but it gives just a framework here to talk about what happens in the brain when people get addicted. And an important concept for me to understand before, when I was just working in a different model, was the idea of salience. I'd never really thought about it before, which was the idea that something that gets our attention in a profound way is salient. And that's what drugs of abuse do. They really get our attention. And when we use them, they get our attention in powerful ways, and that can be negative and positive, but they get our attention. And for some reason, our brains are drawn to salience for survival reasons. And that reinforces a lot of the behavior that happens with addiction. Next slide. So again, it has to do with dopamine, and we know now where this occurs in large part in areas of the brain. So we've identified locations in the brain where people who are getting addicted are experiencing surges in certain neurotransmitters that become reinforcing and become literally changes to their brain structure. Again, if we take this kind of information and we take it to heart, we're really understanding that patients are developing changes in their brains as a result of the use of drugs. And it's not just dopamine. There are other neurotransmitters that are involved that include opioids, cannabinoids, GABA aminobutyric acid, or GABA, and serotonin, and that these neurotransmitters also play a role. And we'll see that in our patients in the drugs that they use. And it also explains, though, why we do need to be mindful about what other substances they're taking and how they can interact in their brains. And we all are familiar with, next slide, the withdrawal stage, where patients who are now in the early abstinence state of using experience a lot of negative affect. They experience depression, or what we call anhedonia, where they don't experience pleasure in a normal way, and they have increased sensitivity to stress. They don't handle things as well. They don't have good coping skills. It's not just a matter of their previous lack of coping, although that does play a role. It also has to do with just a state of withdrawal. And it's definitely a biological state, and we have to address that if we're going to be successful in treating people with addictions. We can't just tell them to tough it out. We're not going to be successful with helping patients when we do that. And the next slide is the craving stage. After patients get through maybe the acute withdrawal, most of the patients who relapse with opioids really relapse in part because of cravings. They'll tell you that. And again, that's not just simply a choice or something that they're doing on their own. There's a process that's going on, a biological process that they're responding to in their brains that we've been able to identify. And next slide, which is just a summary slide of some of that. And again, this is the next slide, which is the mesolimbic dopaminergic circuit, which sort of identifies lots of the different substances and how they sort of cross-react with each other when people use them, and how they interact with this main mesolimbic dopaminergic circuit, which is considered sort of the main highway of addiction in the brain. And again, not to make you into a neuroscientist, and I don't consider myself really a neuroscientist either. To me, it's more important to appreciate this, to understand that there's something going on here beyond character, beyond personality, just beyond will, and that and we've been witnessing that for a long time. So when we're dealing with these complicated patients, we're really coming up against these forces. Next slide. All right, hold on. All right, so this is the list of common co-occurring substances we're all probably familiar with. I do want to say a few things. I added, I work in a program right now with patients who are being diverted from the criminal justice system. So they're coming out of prison or they're coming out of jail and they go to residential treatment or intensive outpatient treatment with maybe a halfway house attached to them, which is very similar to residential treatment. So we are seeing a lot of diversion in that population, meaning they pass around and use substances, use prescription drugs for other than their intended purposes. And so I wanted to mention that in this slide too. But, you know, we still see, again, we were seeing patients who were coming in with heroin and fentanyl, and then we started seeing more and more relapsing with methamphetamine in Louisville, and then cocaine, which never went away, but seemed to be making a comeback. And we can never forget alcohol, and I'm going to do a few slides on all these, including marijuana and sedatives. Xanax has been sort of a really up and down presentation in patients, seeing patients come in at different times. It probably depends on when they have access to these pills. The pandemic has certainly affected that. So I haven't seen as much Xanax withdrawal as I was prior to the pandemic. But, you know, I imagine we may start seeing that again more and more. It's a real challenging problem to treat for withdrawal purposes. And you usually see that with patients who use opioids. In the program I'm working at, I see a lot of Wellbutrin diversion. And I just wanted to bring that to people's attention. Patients who want to snort bupropion because they get a similar experience that they do when they do stimulants. So a lot of patients have learned to ask for this drug and they get it. And maybe they benefit from it and nothing else works, but be on alert when you hear about patients who say, I only want bupropion. And it of course depends on the setting too, but I've seen that being misused quite a bit. Also quetiapine. And I do think these can be really helpful medications, but I do want to be aware of patients who are going to be misusing prescriptions. And this isn't some definitive list. There's, I'm sure, a lot more to it. But you need to be aware of prescription meds are being abused as well as other substances. And it's what people have access to. And that determines a lot of this behavior. And of course, tobacco. Can't forget about tobacco, and we shouldn't give up on it. We should continue to try to help patients try to stop smoking. It's a huge cause of morbidity and mortality in our patients, and it reduces, in the long run, relapse rates when you can get people to quit smoking. I'm not going to say I'm real successful about that, but I work really hard with patients, and I've had a number of successes that I'm proud of, and it's an ongoing battle with this problem. It's not something you give up on. But if you reduce someone smoking, you've still helped them. So, all right, next. So, methamphetamine use has just been increasing in prevalence, and in our university hospital, we're seeing more and more IV meth use along with IV heroin use. It's been there, but it seems to be in some ways overtaking the incidence of heroin. But generally we see both together, and we could probably argue that patients are using both these together. I have been corrected by a friendly person who was I was saying that most of the patients say that they're using heroin, and then maybe meth was put in their heroin, or heroin was adulterated by meth. And I don't think that's probably accurate. It seems like that patients know they're taking both, and they're getting them separately and using them together. Again, this one's a tough one when it shows up, and it doesn't require medical detox from a standpoint of someone's going to have medical consequences from the withdrawal, but the detox is still profound, and patients have significant symptoms, dysphoria and agitation. despite the fact that it's an amphetamine and you think people would crash, which they do, they'll have oftentimes persistent symptoms of psychosis, paranoia, even after they stopped using. We see that a lot in the patients who come into our treatment programs in Louisville. And again, they all have post-traumatic stress disorder. And we'll start to get into PTSD a little bit with this talk. That becomes really important when you're treating these patients with polysubstance use, as it would with any. It's just important across the board. But when you're thinking about how do you approach these patients with these multiple addictions, you've got to think about post-traumatic stress disorder. And interestingly, I think in my experience, somebody can comment on this and later on, which is that when patients are using meth, I think the denial is worse in some ways. It's pretty bad with heroin, but I've got patients just absolutely refusing to acknowledge that they're using, despite all the evidence to the contrary. It's obvious. We have plenty of evidence. There's no real benefit to them denying it. Like there might be, legal reasons why somebody might hang on to, they're not using, but in these cases, it's not. It really seems to be more of some sort of intrinsic or innate denial about methamphetamine, and maybe a property of this drug that people just refuse to acknowledge they're having a problem with it. There are no FDA-approved medications for amphetamine addiction, and that doesn't mean there haven't been attempts or that we've tried. We've tried with prescription amphetamines to try to show that you could treat amphetamine addiction, and it's not been successful. That's important to know. So we don't have FDA-approved treatments for that. There is some hope. There's always a few things that we're hoping for in the works, but really, you don't have medicine to offer, and that's just important to understand. Again, a lot of these patients need to be, in order to get them to really stop, they really have to be removed from access, which is old-fashioned residential treatment to interrupt the cycle. And the other thing about meth use that's important is that, somebody says, "I'm clean, Dr. Stewart. I haven't used in 7 days." And to me, that's not clean from meth, because, you did that when you were using meth. You stopped, and you would stop for 7 days, and you were still in the cycle of use. Now, I don't say to them, well, talk to me when you I don't try to reduce their enthusiasm, but in my mind, I'm thinking, you're not really clean. You haven't really gotten out of the cycle of your use. And that's particularly with the stimulants, where you see, in my view, a binge pattern. And that's similar to what we saw back with cocaine, or what we still see with cocaine. Next slide. This just showing how the use of amphetamines has really gone up since the 90s, and the number of overdose deaths involved have gone up. This is from the CDC. And again, psychostimulants and any opioid have gone up. You can see that. And so our patients are using both. It's very challenging, and it makes it more complicated and difficult to treat, for sure. Next slide. So more bad news is the co-involvement of opioids involving cocaine, opioids, and psychostimulants is going up. And we all know this, but it's verified by the data. There's different information here about the region, but again, it's going up, and we're trying to catch up and struggling to figure out what to do about this. Next. And I want to move on. So what I don't do, and I'll go ahead and say it here, is I don't stop MOUD because you're using methamphetamines. And I'll talk a little bit more about maybe some other things that I do with patients who are in treatment, but we don't stop treatment. In fact, if I can keep somebody engaged who's using methamphetamines, I really think that I'm doing a really good job. I want to keep them coming back and keep working with them. But so many patients who really are severely addicted to meth fall out of treatment, disappear for periods of time, or eventually they wind up at a higher level of care through the ER in our program. And then we'll see them and work with them. And so I keep working with folks who are using meth, and keep it providing education, but also understand that, has a powerful hold on people, and their judgment's severely impaired around the use of that drug. So again, I'm not going to want to punish people for doing that. I want to try to continue to engage them. So that means I'll still prescribe them MOUD, and we can talk, in there. But what do? I probably use shorter supplies of medicines. I'm going to be a lot more. I'm going to ask them to come in more often, although they're going to have trouble with that. I'm going to see them remotely when possible. With the pandemic, we got really challenged around that. But quite a few patients will comply with the drug screens, and I'm okay with drug screens that are positive if it's consistent with what the patient's telling us, at least in continuing treatment. I'm not saying I'm okay with continued drug use, obviously, but I'm not going to be seeing that as not being a patient. Things that to me, that would be, outright diversion, where patients are taking medicine and selling it and trafficking medicine that's not in treatment. But most patients, even patients who divert some, are probably still in treatment. And if we have time, we'll talk about that at the end, what I see, how that looks. I want to mention alcohol. I don't want to leave alcohol out of the story. It's very important to consider alcohol. And again, I ask patients about it. I tell patients at the outset of treatment that alcohol is part of the drugs that we consider on the that you're to abstain from when you begin treatment. Many patients are like, "Well, I never had problems with alcohol. I could always have a drink or two," and they may even be accurate when they reflect that. They may have not had a problem with alcohol. I still say I ask you to please refrain from alcohol use while you're a patient, and we're going to test you for that. And we do. We have labs that test for alcohol use. The alcohol would be if you have a problem with alcohol, which we do see, and I think I can say for sure with a handful of patients that I have, that being a patient in MOUD in our clinic helped identify their problem with alcohol that they had for quite a while. And they got in treatment for alcohol on top of the fact that they had this problem with opioids. And there's plenty of data and anecdotal data, but also the data about patients who were sober on alcohol, got prescribed pain medicines, and relapsed with alcohol. So we know that alcohol and opioids certainly have overlapping pathways in the brain, and that's why we even have medicines that work on both pathways for both problems. Specifically, I'll say naltrexone. And that's what I'll say is, if you got a patient who's entering treatment and they've been through detox, or they've been through the prison and they haven't relapsed, then those patients sometimes are better candidates for a drug like naltrexone depot or Vivitrol, who have substantial problems with both those substances. It might be a better choice than giving buprenorphine naloxone to that patient. Because if they get the depot, they've had the shot for the month. And so I'll think about that sometimes when I'm trying to select a treatment for someone. Most of the time, patients haven't had the ability to detox from opioids. And so they're not going to want to go through a detox and get on Vivitrol. They want relief. And so it's just really not a realistic option for a lot of our patients in the medical hospital. I do use alcohol use monitoring via drug screening. I also have some patients that can afford SoberLink, which is a breathalyzer device where you can breathe into your phone or the device and it records your face. And when you're if you have impaired professionals or people like that, who you can be really useful to use SoberLink. And I think that's been around a long time. It might be becoming more accessible to the general public, but it's still, cost is still a factor in that. But I do find that very helpful for people. And alcoholism is still a real challenging problem. And there are patients that we see with real severe life morbidity from alcohol. I don't want us to forget about it. I don't think we're going to, but in Kentucky, it's a popular drug. It's a popular substance. It's popular for all kinds of reasons. And again, it causes a lot of problems. All right, next. Tobacco too. So interestingly enough, this slide I thought was interesting because of the increase in e-cigarettes after treatment. So patients still think that e-cigarettes are better than smoking cigarettes. I don't think we can say that the evidence supports that, but there's definitely been a consistent trend of increased vaping, getting your nicotine through vaping in patients who are entering treatment. And almost, quite a few people smoke tobacco, 82%, 78% at follow-up. We're not really making a dent there. And I don't think we're trying, probably. Maybe that's learned helplessness to some degree, but I think we have to keep trying and try to do better if we can. Next. So marijuana. Well, I used to discharge people from treatment for smoking marijuana. I used to say, I'm not going to give you medicine if you continue. I'd work with people for a while. I'd give them 6 months, and then I would discharge them from treatment if they wouldn't stop smoking marijuana. I no longer do that. I don't know if that's the right thing or the wrong thing. It's just, I think in my opinion, it's, not justified to stop treatment just because you smoke marijuana. There needs to be a further assessment of that. If treatment's still benefiting you, is treatment providing benefit? I think probably in some of the patients that I discharged from treatment, they were still benefiting from what we called MAT back then, or buprenorphine years ago. We see an awful lot of co-occurring marijuana use in patients with opioid use disorders and who are in treatment. And I know you all see that. This was a study that I thought was just interesting. It showed just the rate, not necessarily that legalization in this study was being looked at and did it change the rate of use of marijuana, which it really didn't. But it also showed among people who were being treated for opioid use disorder in Canada, the rate was 50% of half of their patients used marijuana, pre and post. They didn't really change that. And I don't think that's good. I'm not celebrating that at all. But again, it's not a reason to end treatment for medications for opioid use disorder. It is something to address. So I'm going to talk about that a little bit. Next slide. The most psychotropic drug used in the United States is marijuana, and adolescents that I have a lot of concerns about. The young users are still very high with marijuana, 11.8. I think the numbers are continuing to go up. Next. Synthetic marijuana is very dangerous and has a lot of severe medical side effects we see in the hospital whenever we have this drug that is being widely used in the community or passed around in the community. We eventually find out pretty quickly at the hospital because of the severe medical consequences that occur in our patients with this. So again, the reason is it's much more potent, active at what's called the cannabinoid receptor than the naturally occurring cannabinoids. And so it's just much more dangerous. Next. Marijuana itself is not the same drug it used to be. The THC content in marijuana has risen every year. It's cultivated, and the potency of THC has gone up and up and up. And that makes it a different drug. It makes it more likely. Other drugs of addiction that we've seen makes it more of a drug that causes withdrawal, tolerance, dependence, all the stages of drugs of addiction that we see. And I think it's become more and more of an addicting drug with the cultivation of it, despite the fact that it's being promoted, strongly as medicine, which is not supported so far and by many of the conditions that it's been, touted as being helpful for. But it's also something that's not going away. Next slide. Interestingly enough, there's no link from the National Epidemiological Survey between marijuana and mood disorders. There's associations, but with increased risk of alcohol use and nicotine and marijuana, but not mood and anxiety disorders among all the people who use marijuana. I don't know what I think about that, if that's really reflective of, that's not definitive, that's not the end of the story. I certainly think that marijuana causes a lot of mood problems, but we don't have evidence that it does in strong ways across the board. We see patients who are vulnerable, and so there's more to the story, a lot more to it. But go ahead, next slide. It's not as addictive as other substances, and this slide reflects about 10% of the marijuana. This is from NIDA. 10% who ever use marijuana become daily users. And that gives you a little bit of comparison to other substances. So again, it's a pretty low, lower than tobacco and other substances there. Heroin's at 23. Next. It is addictive. So the answer to the question is yes. Next. So again, marijuana is addictive, and it's not a treatment for opioid use disorder. It is not. I should have a slide for this, but maybe you're familiar with the fact that there was evidence that among states who had legalized marijuana, the rate of overdose death among opioids had gone down. And this had been looked at, and there's really no association. Turns out there's not a relationship there. And thankfully, there was a resistance because there's immediate urge by many places to want to pass marijuana laws because they thought it would counter their rate of opioid overdose that were going on in the communities. And I was living in Oak Park when this was happening, and there was a proposal at the city council in Oak Park up in Illinois to do this. And and you had a powerful lobby in the marijuana advocacy lobby that was also really wanting to take advantage of this and say, you smoke pot instead of opioids, you get better outcomes. And I have not seen that. In fact, I see marijuana associated with more problems, not less. More problems with violence, and more problems with depression and anxiety. But I'm not going to stop treatment for opioid use disorder because someone's so. Okay, so I'm not talking about medical marijuana or what marijuana does have some medicinal. There's evidence that it has some benefit for nausea and pain related to cancer. There's definitely some benefit. How much benefit is challenging to say. CBD it's real popular right now. There's actually some approved drugs. Excuse me, I got some dogs here. There's some approved drugs that have been approved by the FDA based on CBD preparations for very, very specific conditions. Patients who say they benefit from smoking marijuana for chemotherapy-induced nausea. And there's some support for that, but it's still not great. It's still not like really great support in the literature. But but a lot of patients want to say, I smoke pot and it helps me deal with my mood, my anxiety, my PTSD, and it helps me stay sober or stay away from opioids. I don't know that we really can say that's supported. So good question. Keep doing it. Kratom. I see this more and more. I've seen it at times. I saw it in Chicago several times, and I've seen it in Kentucky, where patients have come in addicted to kratom that they were buying out of a convenience store or a place like that, and it's just something to be familiar with. And we do test for it. We test for mitragynine and hydroxymitragynine in our urine drug screens. It really is, I kind of think of it really like an opioid. It supposedly is both like an opioid and a stimulant, depending on the doses. Patients who are taking kratom at high doses and then withdrawal have a very similar picture to opioid withdrawal. It is not, in my view, there's no evidence to say that it can treat opiate addiction. So when you have patients using kratom, I kind of consider this like other substances, or if they relapse with opioids or used other opioids. And there is evidence that you can treat kratom with buprenorphine. That could be helpful. I have patients I'm treating for right now in the clinic who are on buprenorphine and had a problem with kratom and they stopped with prescription of buprenorphine. But it isn't exactly an opiate. It's a little more complex than that. And it's just something to be aware of. And again, it's another one of those. So, and not everybody tests for this in their programs. Oh yeah, that's a good question. It's got all kinds of slang names, and but yeah, they'll say a lot of times in shops when you go by, we have kratom, come and get some kratom. But yeah, and it'll have other names, brand names. I don't know what those are, but the patients that I've treated have all referred to it as kratom. They didn't refer to it as something else. So, are you aware what the name is? Whoever asked that question, feel free to put it in there. I'll say it out loud. Next slide. So I mentioned post-traumatic stress disorder, and that's the thing that to me really connects all of these patients and their use of multiple substances It's a common theme. It's not to say that one addiction is the same as the other, but they all have post-traumatic stress disorder and they all meet criteria. In my experience with PTSD in the DSM-5, and we do see other, bipolar disorder gets mentioned an awful lot in psychiatry, and people get this diagnosis quite a bit, probably more than it's really justified. But other mood problems, anxiety, depression are just known to be associated with patients with multiple substances. And when you do or use multiple substances, you're going to cause a lot of emotional dysregulation. But most likely, and most of these patients had problems prior to use. So many of them start using when they're very young. To say that they had problems before use, they were so young when they started, it's hard to do that. But we'll talk a little bit about that. People with co-occurring illnesses have a higher risk of suicide. And I think about that a lot when they use substances. They're less likely to engage in outpatient treatment. They're more likely to present in higher, more acute settings. And then fortunately, a lot of times in our acute settings, we don't do a good job of connecting them to services that they need. This really had been a problem, and it's still a problem with the silos that we use in our systems of treatment. So we have patients who are treated over here in the mental health system, and then patients who are in the addiction system, and they're separate. And that's been chipped away at, but it's still a problem. Next slide. And again, people are depressed when they stop using substances. So it's hard sometimes to say they have a co-occurring mood problem when they're depressed because they just quit using, because it could be in post-acute withdrawal. But just because it's post-acute withdrawal doesn't mean it's not dangerous. It doesn't mean we shouldn't be aware of the risks of suicide. And I'm really speaking to psychiatry here, so I apologize if this is something that, but we kind of, at U of L for a long time, we ran our emergency psychiatry services. If you were using substances, well, then you really weren't suicidal. If you said you were suicidal or you tried to kill yourself when you were drunk and you sober up and change your mind, well, that's okay. You can go. And that's really not a good way to assess, evaluate, or treat this problem. Particularly those patients are at greater risk of actually killing themselves. We still haven't completely reckoned with that. And I also kind of think that the overdose patient, the patient who overdoses on narcotics, should be treated more like maybe a potentially suicidal patient. Our system can't deal with that right now. But I think that's, that would be important. There's a growing voice that's saying that, hey, this is these patients are still, they're all dead when they die. And whether they killed themselves with the intent of suicide in their mind, do we, when they're doing something this self-destructive, this blatantly suicidal, do we need to consider maybe that's suicidal behavior or not? And again, it's just important that this risk of death in these patients is high and the risk of suicide is increased. Next slide. So people coming off of cocaine or a stimulant too, you need to be really aware of the fact that there's increased profound depression that occurs in like the first 48 hours, particularly the first 24 after they're coming down. They're more likely to attempt suicide at that time. I don't know if it's 62 times more likely, if that's really true. This is from an old epidemiological catchment area study from several years ago. But again, it's much more increased in cocaine. And of course, we know that a lot of people who commit suicide and kill themselves are using substances, and are intoxicated on alcohol, which disinhibits them. So I like to mention that in all these talks. Next slide. So you treat patients for polysubstance use. You come across bipolar disorder an awful lot as a diagnosis. I have a history of bipolar disorder. I was diagnosed bipolar. That's what patients tell me. They'll say, my doctor says I'm bipolar, or my husband says I'm bipolar, or whatever. It's almost become sort of just a word to describe sort of mood swings. But it's a specific illness, and it's been around for a long time. And this was a real problem and continues to be a real problem when patients who had presented treatment with a history of this, and they would be prescribed lots of medicines. And then when you get in and you did a structured clinical interview, you found that many of them didn't meet criteria. And it's challenging because it's not always easy to identify patients with bipolar disorder. It's one of those that can be misdiagnosed for many years. we decided to try to do a small study and with Dr. El Malik, who's the picture in here. I don't see his name on this slide, so I apologize for that. He's one of my teachers, and he's also a professor of psychiatry at University of Louisville, still there, and our expert in pharmacology and the treatment of mood disorders. We did a study years ago where I did SCIDs, or structured clinical interviews, on patients who would come into the healing place who said they had bipolar disorder or had evidence they'd been treated for it. So we did SCIDs. We found that about a third of them did, in fact, meet criteria. 2/3 did not. And this was replicated in several other similar programs a couple of years later. And in a large scale in Rhode Island, they did a much larger study of looking at bipolar disorder. And it's pretty much consensus now that that gets overdiagnosed in psychiatry. It also gets missed. So people who actually have it, unfortunately, don't get identified. And a lot of people get identified as having it who don't. Part of the reason is substances that people use make people present as mania or even psychosis. And so you see that with meth a lot. So I ask, have you had a sleep disturbance? And even though at least I want 7 days, but don't always get it if I'm going to diagnose that. But if someone has these symptoms, we're still going to probably treat them if they're persisting after a week or after several days of not being on drugs. If they're still having manic symptoms, we're going to treat them for mania. But we may not give them that diagnosis to follow them the rest of their life, or we may not. All these patients, again, have PTSD, which also has to be considered. And that was the big finding from doing this research that I found, was doing SCIDs. The majority, if not all, patients had severe early childhood trauma in their adult years, trauma from their substance use, and they had symptoms of PTSD. And that was almost 100% of all the patients. And then that has been, I think, validated in the literature as well, that it's a very high co-occurring rate of PTSD in patients who are homeless, and with substance use problems. But I think among most of our patients with substance use problems, it's very high. I think we're not really good at identifying PTSD in psychiatry. Still to this day, it's, I think, minimized by psychiatrists. Next. Again, this was the paper we published in 2006, where we found, is it overdiagnosed among substance use disorders? Yes, it is. And then nobody wanted to publish this at the time. It was really met with a lot of hostile criticism, but it's been repeated. Their findings have been replicated, and then even at a larger scale. And like I said, in Rhode Island. Next slide. So this led me to discover, maybe many of you know about, that I didn't know about at the time, the ACE study, which was a study that started in California in the late 90s and was started by the partnership with the CDC and Kaiser Permanente, where they really were wanting to do a really thorough dive on the management of obesity in their patients. They wanted to solve the problem of obesity to save money and to try to prevent obesity in patients. And so they followed patients for a really long time. They had a huge number of people they followed. And what came out of that wasn't really an answer per se to the obesity problem, but was really this finding about adverse childhood experiences and their linear association to health problems, including substance use and mental health problems, but also chronic medical problems. And linear means a dose-response relationship, meaning you increase the dose, you get an increased response, and it's just a straight line that goes up. That's a profound finding, in my opinion. And it's been a very influential study. And again, to me, adverse childhood experiences translates to loosely the spectrum of post-traumatic stress disorder. All of our patients have high ACE scores that we see. And therefore, what we're treating a lot of times, I think, is, particularly when I think about patients who use lots of drugs, we're treating early childhood trauma and the ramifications of that have gone on. Next slide. Here's examples of adverse childhood events. Many of you may know this. Go ahead. Next slide. And again, I like this because it sort of puts together chronic medical problems as well as chronic mental health problems together. We see these consequences side by side: diabetes, hypertension, and depression and substance use side by side, because they are together. They are side by side. They're all related. And we need to see them as medical problems, and this is part of why I think I find this study so appealing and vindicating in many ways, is because it really says we need to care about this, because it does. It has real tangible costs. We need to address it. And when we see patients, we can't go back and change their past, but we can understand our patients more deeply with this kind of information, and we can be more helpful. Next. The other thing that's important then is, okay, so I kind of presented this problem of making the diagnosis, the psychiatric diagnosis in patients who are using multiple substances. It's challenging. But one really nice pearl is that, in contrast to other psychiatric problems, you can make the diagnosis of post-traumatic stress disorder with less abstinence to establish it. And in fact, maybe even during acute detox or when patients are actively using, you can reliably establish that PTSD is present. You can't do that with psychotic disorders as easily, or what we call patients with other mood disorders. But I think you can much more reliably identify trauma and PTSD. And PTSD nightmares are a big symptom that I see in patients who come into treatment and that often don't get addressed because it's kind of wrapped into their detox. Next slide. I mentioned these medicines just because they don't get used as much, I think, as they could be. They're not a panacea for PTSD, but specifically clonidine, which gets used a lot for opioid withdrawal in the past, but guanfacine and prazosin get used. They're called alpha-2 selective agonists. They're really blood pressure medicines. They lower blood pressure. They don't get used a whole lot for that either. Some clonidine gets used a lot in the hospital, or it used to. It's used less now. But they work centrally in the brain, and they really kind of suppress the fight or flight response. Now, guanfacine, as known as 10X or Intuniv, has also been used to treat ADHD in children. And I think that's probably not a coincidence that, children who've probably endured trauma or have unidentified trauma and anxiety are benefiting from a drug like this, who get labeled ADHD. Not that you can't have both, but that a lot of times what you're dealing with is, children who are in environments that are really, really stressful, and they get diagnosed with ADHD. And then these drugs work for that. They work because I think they really help with PTSD. So I use them in patients with substance use problems. And it's also nice because they don't have, in my experience, any reinforcing virtue, any reinforcing properties, meaning that patients don't want to keep using clonidine, guanfacine, prazosin, and getting high or a sense of high. There is street value for clonidine in Louisville, and patients that I treat in the Moore Center, which is our methadone program, one of our methadone programs that uses methadone. I've had patients educate me about that clonidine can be sold for money that they can use to buy substances with. So that's not completely off the hook around that. But again, it's because it helps with mediating the sort of stress state of opioid withdrawal. And it's because it does that, it's also good for dealing with PTSD. But specifically, post-traumatic stress disorder nightmares seem to benefit, a lot of patients seem to benefit by using these medicines, which can be really profound early in treatment when someone's trying to stay sober and they stop using and they start having lots of nightmares. I see this a lot. Intrusive nightmares, intrusive flashbacks, intrusive experiences that really, in part, have to be involved in driving their substance use. And if you can give some relief to that early in treatment, you improve, I think, adherence, and you improve outcomes substantially. It's not easy to do, and these medicines definitely don't work like a magic bullet, but they help a subset of my patients, and they've often not been prescribed these. Prazosin gets prescribed the most by psychiatrists, and I think that we need to try to use the other ones a little more too. Next slide. So again, considerations in relapse. I talked about this a little bit before. This is a little different way. So other things that could be going on is unaddressed PTSD, other mental illnesses. Many times I've had patients who are being exploited, human trafficking or other types of exploitation, and they are definitely not going to come out and tell you about that right off the bat. You have to develop a relationship with somebody before they begin to sort of let you in on this situation that they're in, that they need help with. I also believe and have experienced patients who develop process addictions, meaning sort of like eating disorders, anorexia, bulimia, but other types of eating disorders, gambling disorders, sexual compulsive behaviors that have interfered with people's recovery substantially and with their mood. Reasons why their mood isn't getting better is because there's process addictions that aren't being addressed. So I like to ask about that. And ongoing medical problems, chronic pain is extremely important. A lot of times patients don't appreciate that. They don't understand. They haven't really thought or conscious of the fact that their medical issues could be contributing to their trouble with staying sober. Sometimes with pain, they can often be aware of that. And I mentioned Maslow's hierarchy because I like to look at things that way. I'll say more about that. Go ahead. So Abraham Maslow's famous psychologist, transpersonal psychology. I've been informed that maybe he didn't use this. He didn't say he didn't come up with a hierarchy of needs, but it's sort of been taken. Somebody took his stuff and created this. I don't know. I really like it either way. And I like the idea of that there's a hierarchy of needs that patients have. And when we evaluate them and we're treating people for substance use problems, we have to think about what their needs are. So a classic example is pregnant women who, need services. Okay, so me preaching the 12 steps to a woman who's 4 months pregnant and addicted to heroin and in withdrawal, that's not going to help her. She needs services. She needs a place to be safe. And she probably needs, if she's on heroin for sure, we want to really talk about medication for opioid use disorder with her. And that also we don't need to, shame these patients, and they need to be able to access treatment so they can get better outcomes. I think we're doing better with that. But again, the hierarchy of needs really comes forward in that. But the other patients have needs too. They need a safe place to be. Safety is a big deal. I think that's a big one. A lot of patients aren't really safe. And I think safety in terms of ongoing drug use, being around drugs, but also having enough food and having enough shelter. And so if you have those kinds of problems, then you're not going to be as successful if you don't address those kind of problems with helping somebody get clean. So next slide. ADHD comes up an awful lot. People get sober, they get in treatment, they're early on, they're doing well. Can you treat my ADHD? Translation, can you prescribe me amphetamines? Not always treat. Sometimes there's genuine, hey, I need help with this. I'm not interested in taking stimulants, but most of the time it means I would like to be prescribed amphetamines. And then the next thing that patients say is I was prescribed amphetamines and they really calm me down. So I have ADHD because if amphetamines calm you down, it means you got ADHD. So would you be willing to do that? And this is a legitimate request. I don't think it's a manipulation by the patient or somebody trying. This is how they feel. And the important thing for me is not necessarily what I say in that moment, but I'll listen to them and want to understand more about the problem. But that amphetamines calming someone down is not diagnostic of ADHD. In fact, that's what amphetamines do. They calm people down. People think that's a paradoxical response. It isn't. It's what amphetamines do. If you take too many amphetamines, you can get maybe elevated, irritable, agitated for sure. And chronically over time, we see a lot of disturbance like psychosis. But when you get a dose of amphetamine that increases your attention and focus, you calm down. So for patients who have ADHD, these amphetamines can be very, very helpful in helping them focus. But it's not unique to patients with ADHD that they have this effect with amphetamines. It's been used for a long time to justify prescribing tons of people amphetamines, in my opinion, who may or may not have ADHD, but they just want performance enhancement, which they do. You will accomplish that with stimulants. The rate is, pretty low among patients who come into addictive treatment programs. It's probably is higher. Having ADHD definitely increases your risk to having substances and addiction problems. If you don't treat ADHD in a kid, I think there's some evidence that says, hey, you're more likely to develop an addiction later as an adult. What we have shown is just because someone has ADHD and now is in recovery and had a problem with substances, giving them amphetamines isn't going to change their chances of recovery. It doesn't mean we shouldn't offer the best treatments for them and try to assess it. But and I do have patients that I prescribe amphetamines to who have had a history of addiction and alcohol-related drug problems. So I do that. I'm not against it, but I do see a lot of people early on in treatment who have a history of methamphetamine use, bringing that up. So next slide. So that's controversial. The person asking, is there a proven correlation between early ADHD treatment? Actually, it's controversial. Some have said, they actually pointed that if you treat ADHD early on, you get less likelihood of drug and alcohol use. But I think the safe thing to say is if you have ADHD as a kid, you're more likely to have substance use problems as an adult. Can you prevent that by treating ADHD? There's some evidence to indicate that. If you're aware of particular research about those specific drugs like Concerta, Ritalin, or I'm not aware of that, but it might be out there. This study, and I'm not really the ADHD person or the expert in ADHD. I don't want to present myself in that way, but you treat a lot of people who have had that history and diagnosis when you treat addiction. So if I'm an expert on anything, it's that group of people who are entering in my world who report this history. And I'm aware of a whole lot of population of patients who have this problem who don't necessarily wind up seeing somebody like me. I'm not going to be as an expert on those patients. But clearly people with this problem have a higher rate of substance problems, and not just with amphetamines, but with all other types of substances too. And the review of, so this was a study that came out in 2017, but I thought it was really important. The study was showing that, okay, among people who are diagnosed with ADHD, so this is 3 million people, which is just huge. That's a huge number. This was done in Indiana, I think out of Indianapolis, Indiana University, at the medical school there. But among the people, they looked at claims across the country, and this was published in the Green Journal of the American Psychiatric Association. But people who had received either ADHD diagnosis or treatment with stimulant therapy or other types of medicine, they looked at visits to the ER and ambulance calls and other something related to either accidents or something like that. What they found were medication periods were reduced with a risk of substance-related events. And what they said was this is one association, and in the report they said we can't make conclusions that people who stop their amphetamines are gonna, wind up in the hospital. But it did sort of raise this idea that if we don't treat ADHD, we get more of these substance-related consequences, and that we can reduce substance use by treating ADHD. This is just an ongoing debate that we continue to have, and there's mixed evidence on both sides from where I sit. And I think it can't be just discounted. You can't just say you're going to be on one side and be fine. You're going to have to look at this and really think about it. And you can see cases where patients maybe have severe ADHD that if it doesn't get addressed, is going to be really hard for them to manage their life, and that they're going to be less likely to stay clean and sober. And again, but I also think there's a huge push to want to try to simplify things and simplify treatments, and understandably so. And, let's just prescribe amphetamines for patients with ADHD. And, we'll always be dealing with that too. And we need to be aware of that. It's probably not going to work. It's going to be, again, complicated and require a lot of support and other types of services. And we're going to address complex things like mood disorders and psychiatric diagnosis, psychiatric illnesses and addiction. Next slide. Again, this is a proposed risk stratification table that I include. It's interesting. It's not definitive. It's not like this is the standard. This is a consensus that comes out of ASAM, one of the ASAM textbooks on ADHD that I mentioned here. So you have low risk, moderate risk, and it just says there's an approach that we could possibly use. High risk group, active substance use. You're going to try non-stimulants, and even in the high risk group, they're talking about how you can use stimulants. Possibly, and using long-acting stimulants over short-acting stimulants, that kind of thing. I haven't found that there's really no safe way to use stimulants in people who are actively using. And I'll tell you what I do with patients who are wanting amphetamines, but in the program. This is what I do. I'm not saying it's the right thing to do, but I'll say, okay, you've been here long enough. I'll consider it if you'll stop smoking pot, and you won't do any other substances. No alcohol. I can't even have a drink. No, you can't have a drink. I'll think about prescribing you an amphetamine if you can stay clean from everything else except what I'm prescribing you. And if you don't do that, I won't continue to do it. What do you think of that? Or I get patients I inherit who come in and they're being prescribed amphetamines. And if I don't give them the amphetamine, I got to decide whether they're going to be engageable in treatment or not, whether it's worth risk benefit. And maybe it is. And then, but I'll make sure that I say, this is the conditions for being on amphetamines. They're more stringent, it's stricter, it's higher supervision and monitoring. Is that okay with you? And if it's not, then I'm not willing to do that. That's been moderately successful. I wouldn't say it's worked like a charm or anything, but that's what I do. That's how I feel comfortable with that. I'm not going to give you amphetamines and buprenorphine while you keep smoking pot. I'm not going to do that. And I think to me, marijuana does not improve ADHD. Believe it or not, patients will argue that marijuana is good for ADHD. All right, next slide. Again, my approach to differential diagnosis is I tend to their medical physiological problems, safety issues. I talked about the ACE score, and then I think about patients from an attachment perspective, and I'll say a little bit more about that as I wrap up. Next slide. Phil Flores wrote a book, Addiction as an Attachment Disorder. He's a group therapist and really good writer about addiction and the psychology of addiction and how group psychotherapy is helpful in addiction. And he talked about Kohut in his book Kohut was a psychodynamic psychiatrist who had a movement that he started called self-psychology, which is just a new type of psychoanalysis. But again, Kohut's real influential, and I think right about this, that it can be construed that addiction is an attempt at repair of the self that fails, and that way can peak, and they can't repair the damage of the self because when they get addicted, they get isolated and they have more emotional dysregulation, and they've got to learn to develop mutually satisfying relationships. So one of your goals of treatment is to help them develop the capacity for that. And it's very in line, in my view, with PTSD and the patients who have experienced trauma in early childhood, that this is kind of what they're doing. Next slide. And again, this is more about secure attachment. I'll move on in the sake of time. But when people are securely attached, they're more liberated, and they're more regulated, and they're healthier. These attachment needs persist throughout the lifespan. So we think about children and attachment needs, but really adults have attachment needs. This is very relevant today with the pandemic. And this is Ed Kansian, who was real influential in this thinking too, but also real influential in the idea of self-medication. He coined the term self-medication. And
I think we might have lost Dr. Stewart briefly. Let's see if he's able to log back on.
It's thunderstorm here, I guess. You hear me?
Back. Yep.
Next slide. So I like Ed Kansian a lot, and this is the Dr. Kohut. Next. AA, then if you think about 12-step recovery in this concept, it's still important. I still try to get patients to go to 12-step meetings. Our meetings are more friendly to patients who use polysubstances. We have different 12-step fellowships and online fellowships in Louisville. A lot of patients go to AA who have other substance use problems. And there's problems with that. I'm not going to get into all that, but I do try to get people into 12-step fellowship when I can, and try to facilitate that. Next slide. So it's difficult to achieve compliance and recovery. Compliance is easier to measure, and that's part of what I do. I try to measure compliance. And if I keep somebody engaged longer in treatment, I'm going to get better results. I don't think just casual contact is enough. I want to get to know somebody. If they're showing up, even if they're still using, and I'm getting a relationship with them, I'll take it, and I'll work with somebody as long as I can, as long as they're showing up. And it's not always, that's challenging. It's very challenging and scary and intimidating to work with patients who are actively using substances, but it's also very rewarding. So again, I'm done. Thank you for your time and attention. I really appreciate being invited to talk today.